Suicide, a word that can stop a conversation in its tracks. A reality that claims over 700,000 lives every year globally, and one of the most sobering responsibilities in the field of psychiatry. When someone says, "I don't want to live anymore," or when a clinician senses something beneath the surface, we are faced with one of the most urgent and complex decisions in medicine. Is this person at risk of suicide? And if so, what can we do right now to help them stay alive? This video is a deep dive into suicide risk assessment, a delicate blend of structured tools, clinical experience, and gut-level human intuition. We'll talk about what suicide risk really means, how psychiatrists and clinicians evaluate it, the tools we use, the warning signs we watch for, and how our own instincts and empathy come into play. Let's explore this with care, compassion, and clarity. The weight of the question. As psychiatrists, therapists, physicians, we're trained to ask, have you had thoughts of hurting yourself? Have you thought about suicide? Do you have a plan? But asking is just the beginning. Suicide risk is not a number. It's not a checkbox. It's a dynamic, fluid, deeply human process. It can change hour to hour. It can hide behind smiles. It can manifest in silence. That's why assessing suicide risk is not just about data. It's about seeing the person, defining suicide risk. In clinical terms, we often classify risk into low risk, fleeting thoughts, no plan, protective factors, moderate risk, more persistent thoughts, vague plans, ambivalence, high risk, specific plan, intent, access to means, few protective factors. Imminent risk, immediate danger, requires emergency intervention. But in reality, risk isn't always linear. Someone can go from low to high in a matter of minutes, depending on life events, substances, or loss of hope. Our job is to recognize those moments and act with urgency, without panic. The role of structured tools. Let's start with the tools we use in clinical settings. Structured tools don't replace judgment, but they provide frameworks. Here are a few commonly used ones. 1. Columbia Suicide Severity Rating Scale, CSSRS. One of the most widely used screening tools. It assesses suicidal ideation. Have you wished you were dead? Suicidal plans. Have you thought about how? Intent. Have you decided when or where? Behavior. Have you attempted suicide in the past? The CSSRS helps standardize language, especially in busy ERs, primary care, and mental health clinics. 2. SAD persons. Scale an acronym covering key risk factors: sex, male age, 19 or 45, depression, previous attempts, ethanol or drug use, rational thinking loss, psychosis, social support, lacking organized plan, no spouse sickness, chronic illness. Each factor scores a point. Higher scores, hélas, higher risk. But be cautious. This tool has limited predictive power and should not be used in isolation. 3. Beck's Scale for Suicide Ideation, BSS, a self-report inventory evaluating severity of suicidal thinking, helpful in outpatient settings to track changes over time. 4. PHQ-9, Item 9. This standard depression screen ends with thoughts that you would be better off dead or of hurting yourself in some way. It's a red flag if someone scores high on this question, even if the rest of the questionnaire is low. Clinical interview, the real conversation. Structured tools help, but they're not enough. The most powerful risk assessments happen in real conversations, where we ask, listen, and feel. Key questions psychiatrists ask: have you been thinking about ending your life? Have you made any plans? What's stopping you? Have you attempted in the past? Are there weapons, pills, or means available to you? What do you feel when you wake up in the morning? What keeps you going? We assess for duration and frequency of thoughts. Intent: do they really want to die or want the pain to stop? Lethality and accessibility of the plan. Ambivalence: are there reasons to live? It's less like interrogating, more like listening between the lines. Risk factors. Who's more vulnerable? We pay attention to risk factors, but we don't let them define the person. Demographic risk factors. Male sex, especially older men. Adolescents and young adults, elderly individuals, especially after loss. LGBTQ plus youth, veterans, psychiatric risk factors, major depression, bipolar disorder, schizophrenia, PTSD, borderline personality disorder, substance use disorders, historical risk factors, prior suicide attempts, family history of suicide, childhood trauma or abuse, recent hospitalization, the week after discharge is critical, situational risk factors, loss of a loved one, relationship breakup, job loss or financial crisis, legal problems, chronic pain or terminal illness, isolation. But again, we don't assess people by their statistics, we assess them by their stories. Protective factors. What keeps people alive? Just as important as risk are the reasons to live. Psychiatrists always assess for connection to family or friends, sense of purpose, spirituality or faith, access to care, hope for the future responsibilities, e.g., children, pets, past ability to cope. Even one protective factor can be a lifeline. Sometimes we help patients rediscover them, because in the dark, people forget what kept them going. Experience and intuition. The clinical gut. No checklist can capture a clinician's instinct. Over time, psychiatrists develop a sense, a gut feeling, based on body language, eye contact, tone of voice, inconsistencies in narrative. The pause before answering a question. The things they don't say. Sometimes a patient says, "I'm fine," but their posture, affect, and energy say otherwise. That's where experience matters. That's where intuition saves lives. What happens next? Interventions and levels of care. Once we assess risk, we must act appropriately and urgently. Low risk, outpatient therapy, medication adjustment, safety plan, regular check-ins, crisis line access. Moderate risk, intensive outpatient or partial hospitalization, daily contact, involvement of support system, removal of lethal means, close follow-up, high imminent risk, emergency hospitalization, voluntary or involuntary, constant observation, 1.1 monitoring, medication initiation, suicide precautions, removing shoelaces, belts, sharp objects. The goal is containment, stabilization, and transition to longer-term support. Suicide contracts, outdated or useful. For years, clinicians used no suicide contracts, written promises not to harm oneself. Today, these are largely discouraged because they may create a false sense of security, they're not legally binding, they don't replace real safety planning. Instead, we focus on collaborative safety planning, identifying warning signs, coping skills, emergency contacts, and reasons to live. This empowers the patient and builds trust. Cultural and personal sensitivity. Suicide isn't experienced the same way in every culture. In some communities, suicide is a taboo, mental illness is stigmatized, religious or cultural beliefs affect disclosure. Psychiatrists must ask open-ended, culturally respectful questions, be trauma-informed, never assume, always ask. Final thoughts. We assess risk, but we hold hope. Evaluating suicide. Risk is one of the most serious things we do as psychiatrists. It's also one of the most sacred, because every time someone opens up about suicidal thoughts, they are showing us their pain, their fear, their inner battle between life and death. And in that moment, we are not just assessors. We are witnesses, allies, and lifelines. No tool is perfect. No psychiatrist is flawless. But when we combine structured knowledge, clinical skill, and human empathy, we save lives again and again. If this video helped you understand suicide risk assessment, please like, share, and subscribe. Drop a comment. What do you think professionals should always remember when talking to someone in crisis? Until next time, take care of your mind. And remember, asking about suicide doesn't plant the idea, it opens the door to saving a life.